my name is Chris Spence. This is my audience. And I'm here to talk to you guys today about permitting nurses to be able to debride wounds in a home health setting. A little history about myself. I'm a home health nurse. I'm certified as a wound treatment associate. I do wounds on a daily and weekly basis. Debridement is the cleansing and cutting away of the dead tissue that is found in a wound. A wound that properly heals will invariably have some dead tissue that needs to be cut away. This practice is typically only done in a physician's office or a hospital. But it's my argument that it can be done in the home health setting, particularly for patients who have expressed and taxing difficulties and problems getting out of their home and to the doctor. Often, patients who get deemed as home health patients are that way because they either have health issues that can't let them get out of the house, they have obesity, they have sickliness, or they're just too poor, can't afford the transportation to get out. So we can save a lot of that taxing effort by simply doing the wound care in the home and debriding in the home. What we're debriding. So as a wound heals, we've all had scabs. Those scabs on a big wound is called eschar. Eschar is thick, it's leathery, it's black, it's dark, and it's dead. Dead tissue. If we can get rid of that, we will reveal very good tissue underneath, healthy tissue called granulation. This granulation is imperative to having good wound healing, so we need to do everything we can to get rid of the eschar and promote the proper granulation. Once we've debrided and we've broken down some of the eschar, we'll have what's called slough. That slough is stringy, it's yellow, it's soft, and it's also dead. This is the actual part that we get rid of. We can cut that away, we can debride all around and inside the wound, and once we've broken down the eschar to the slough and cut off the slough, what's left is the positive, good granulation. There are three major types of debridement that we can do, and the first we're going to talk about is enzymatic. Enzymatic debridement, according to Ms. Bonham from the JWOCN, enzymatic debridement involves applying the debriding agent to the actual eschar. And by applying it to the eschar, it'll break it down, and it actually works on the level of the enzymes in the cells. So what we have to do with the enzymatic debrider is cross-hatch the eschar. Take a scalpel, cut one direction, take it, cut the other direction. That gives us some actual grooves that we can let this gel seep into and start breaking it down from within. There are two types of enzymatic debriders in the market today. There's Santil and there's collagenase. Santil is the most popular. Santil is also very expensive. So it's very important that once we have this eschar debrided, once it's starting to break down for debridement, we need to know to discontinue it and start getting rid of that bad, nasty slough. In the process of doing that, you got to have the patient go to the doctor. And you're having this patient go to the doctor every week, every 2 weeks, sometimes every 3. And it can get quite extensive in the time by setting the doctor's appointments as best as you can fit the patient in. And then that process, you might have a situation where you could discontinue using the Santil or the collagenase earlier than necessary by simply having the nurse, who works on it every single day, cut off that slough as you're going. In the process of using the Santil or the collagenase, you'll simply place a nickel-thick layer onto that eschar. Once you've done that, take some soft, moistened gauze, apply it on top. That's it. It's really that simple. All we have to do is have proper application and then recognizing the slough to cut away. Once we've gotten that eschar broken down, assuming that we've got all the slough cut away, we're going to have what's known as the granulation, as I've mentioned before. The granulation is the ideal tissue that we need for fibroblast reconstruction. The fibroblasts reconstruct themselves in a planar method over the granulations, which is what promotes wound healing. Second method that we can use for debridement is autolytic debridement. Autolytic debridement is utilizing the body's white blood cells to break down the wound. We use moisture control in this method. It's really quite that simple. By taking a simple gauze pad, any sort of our own Telfa pad, put it on to the wound and create a moisture bed, that's going to break it down. But as evidenced by Mr. Dean Frame, it is extremely important that we do not have an immunocompromised patient while we're utilizing autolytic debridement, because if the patient's immunocompromised, such as AIDS or Hodgkin's lymphoma, then we're not going to have the proper white blood cell count and circulatory system to proliferate in the wound bed for breakdown. With autolytic debridement, we're simply going to have our dressing, like I said, that we're going to have over the wound bed, and we're going to check it every 4 to 7 days. After about 7 days at the max, there will be enough white blood cells in that wound bed that will create a moisture control that will break down that eschar for debridement. Once that's recognized by the skilled nurse that's in the home, who better than the skilled nurse to cut that slough away and get rid of it to continue with our autolytic debridement. Thirdly, we have chemical debridement. Chemical debridement is a very common practice in the home health setting. Many home health nurses do it simply by taking a moisture of bleach solution called Dakins, moisturizing of gauze, and applying it to the wound bed. But the Dakins can have adverse effects on the fibroblasts, so it's extremely important that the skilled nurse recognizes when the Dakins has broken down the eschar, so we can stop it, so that we don't have any more breakdown of the fibroblasts, because the fibroblasts, of course, is what we need to heal the wound. While doing the chemical debridement, when we apply the gauze and cover, we're going to check it every 2 to 3 days. Every 2 to 3 days, the benefit out of the deal takes away the odor, and it's also antibacterial and gets rid of infection. Again, we need to have a skilled nurse who's going to be able to recognize when it's broken down the tissue to a point that it can be cut away. So when that slough is ready to be cut away and debrided by the nurse, we got to stop that Dakins. That's why it's important for that skilled nurse to recognize that, and why the skilled nurse should be able to debride the wound there in the home. So the clear and indisputable conclusion to this persuasive speech is to let you understand and recognize that you've got a nurse who is in that home every other day, sometimes every 3 days, week in and week out, with patients who are already deemed homebound who can't leave their home. It's difficult and taxing for them to get out of their house. This is a patient who's become intimately involved with this wound, knows exactly what he or she is looking at. So in the home health setting, why not use sharp debridement to let them cut out this slough and improve the wound status and save the patient the difficulty and time of getting out. Thank you very much.
Good job.
Very good job.